Hi, welcome. Thank you so much for coming. We hope you have enjoyed the food and libation, and as you can see, the lines didn't turn out to be so horrible after all. And we're hoping you're ready to roll up your sleeves and get to work, because this is, even though you're going to get a lot of information, this is actually a working conference, and so we're going to have you do some work tomorrow afternoon. I'm Kay Norris. I'm Kay Norris, the Program Director of the Montana Pain Initiative, which is a project of the American Cancer Society and the American Cancer Society Cancer Action Network.
And I'm still Tamara Knotts. I forgot who I was a minute ago. I'm the Clinical Director for Western Montana Addiction Services. You're probably asking, maybe, how we got here in this room, so many disciplines and disciples together. The Dalai Lama's not here. Those of us who work with clients who are affected by pain, addiction, and mental health issues have a very deep understanding about how complex these people are and how limited our community resources are right now in our three-county area. All of us in this room have experienced the effects of a person who has developed a problem with opioid medication in some form or another.
It's very important to remember or realize that we have a chronic pain public health crisis in this country. 76.5 million people experience pain 24/7. We estimate from national statistics that about 150,000 people in Montana experience pain on a daily basis. Pain is often undertreated, misunderstood, and sometimes avoided. People's quality of life is seriously debilitated by unrelenting pain. However, we also have a prescription drug abuse crisis in this country too. We have to work together if we're going to do anything to solve this situation or even make headway on it. So what we need to do is just really come together in interdisciplinary ways like this, across the community, and really work towards trying to solve some of these issues.
It's common to believe that treatment will resolve all the issues inherent with one who's become addicted to opioid medications, experiences pain, and has mental health issues. This complex client requires more extensive services than most, more time to coordinate care, and subsequently more funding and staff time to provide treatment services. These dynamics, coupled with diminished funding for treatment, require our community to go upriver and coordinate care before it becomes a problem, which is the ultimate in prevention. This is hopefully where we're going to arrive at together at the conclusion of this conference.
To this end, we have an amazing group of presenters for you over the next 2 days, starting out tonight with our own Attorney General, Steve Bullock, who's going to talk to us about what's happening in Montana and his goals for the Prescription Drug Abuse Advisory Council.
Joan Cassidy is going to tell us about prevention and treatment structure and funding sources in Montana.
Tomorrow, Dr. Randy Sechrist and Dr. Steve Kemple will provide an overview of how this conference came to be.
Dr. Dan Knotts is going to provide us with a detailed description of the interaction of addiction, mental illness, and behavior.
And Dr. Steve Pasek will be talking to us about how to effectively treat chronic pain, addiction, and mental illness concurrently.
Dr. Bazell will be helping us to understand how to build an effective community network and manage prescribing risks.
We are also going to have a community panel describe their experiences from 3 different perspectives. So it's my honor to introduce Steve Bullock to you. Mr. Bullock is Montana's 20th Attorney General. Steve has been in public service since the beginning of his career in 1996 when he was the chief legal counsel to the Montana Secretary of State. Steve is committed to curbing prescription drug abuse and reducing drunk driving. He is dedicated to making Montana safer, especially for children. And I have had the privilege of working with Steve over the last year, and we have a meeting of the minds relationship. Steve and I both agree that it is very important in our state that we manage pain effectively while making sure that people are not misusing, abusing, or becoming addicted to their pain medications. So we both feel very strongly about this, and I am very honored to introduce you to your Attorney General, Steve Bullock.
Thanks, Kay, and thank you for the opportunity to be here this evening and to share part of the conference. Certainly appreciate the work that Tamara and the whole planning committee, so look for those dark green bands on the name tags, did to pull this together and to really start taking a look at some of the collaborative and team-based sort of things that we can do. It's sort of curious in some respects, I guess. As Attorney General, I have about a 750 employee state agency. And there are those that run around and say that my job is the state's chief law enforcement officer and chief lawyer. So it's probably a little bit curious that you start out this conference with a cop talking to you, more or less. I think, though, that I kind of realized two things, one of which is that you probably can't have every one of the forums where you can drink cocktails while you're listening to the guy, so hopefully that'll make it more interesting. And also, once I heard who all else is speaking, and it's doctor this, doctor that, they figured they'd set the bar low to start out the conference, and as time goes by, it'll get a lot better. I do think, though, that no matter what our backgrounds are, and no matter what fields we might come from, our professions, when we're grappling with the issues that you'll be talking about over the next couple days, we probably share some common values, and we share some common beliefs. We recognize the legitimacy and the importance of these drugs, and how critical they are for many individuals with chronic pain, terminal, and certain other illnesses. We don't want to prevent those in legitimate need from getting the medicines that they need. We want to make sure that doctors and those in the medical community have tools that they need to prescribe opioid-based prescription drugs with some modicum of comfort, that what they're doing is actually treating the ailment. They're not either feeding the addict or providing a source of diversion. And no matter where we come from, no matter what our backgrounds is, I would hope that we share the common belief and the common recognition that the misuse and the diversion of prescription drugs, it impacts much more than the pill taker or the addict, that the impacts are ultimately spread all throughout our community. And it's something that I've only had this job for, I guess, almost a year and a half now. But it's something that the recognition of it came pretty early, and indeed into the campaign. And it initially came largely from speaking to people in law enforcement. But what I recognized when I'd be out there campaigning, no matter what group it was, I mean, I remember an evening with the auto body repairman people here in Missoula. And invariably, no matter what the group was, after I spoke with it being part about prescription drugs, some individuals would come up with their personal stories and reinforcing how it touches so many facets of our life. And as the state's chief law enforcement officer, I think it's a challenge. And I think it's a challenge unlike that many that we've had in the past. When my predecessor came into office, Mike McGrath, 9.5 years ago, methamphetamines was just on the horizon. That was just starting to impact our communities. And ultimately, it had a tremendous impact throughout the state. And we took a number of steps that I'll touch on briefly as I go on this evening. But I think that in some respects, this is even a greater challenge because we tend to think of drugs prescribed by doctors safe. And it's a challenge because the picture of meth and the picture of prescription drugs is substantially different. It can even ensnare those responsible individuals and make them more than just addicts, but at times distributors or dealers as well. And it can also turn many of us into unwitting suppliers just by the very virtue of the fact of the things that we maintain and keep in our medicine cabinets. The picture of Montana, in part, recent study, I think it was SAMHSA from 2 years ago, found that Montana was third per capita in our adolescents, age 12 to 17. Almost 10% of our kids are abusing prescription drugs. And nationally, we know that I have the Division of Criminal Investigation under me, which is, has drug agents and criminal investigators throughout the state. At a local level, you know, that every one of the cases that they've been involved in, there's never been one of these cases from the internet, or that's not where they're getting the drugs. Nationally, 70% of those that are the diverted drugs, the abused and misused drugs, are coming from friends and family. They're either given, taken, or purchased. Kids, when we look at those statistics about the kids, this is a national level, kids tell us that prescription drugs are free and easy to get. 51% of teens say they abuse prescription painkillers because they're not illegal, or so they think. 56% of teens agree that prescription drugs are easier to get than illicit drugs. Last year, of that Division of Criminal Investigation under me, 42% of the cases in my department, they were related to prescription drugs. Some of the cases involved the established dealers who added prescription drugs to their overall inventory. Investigators are also finding, though, that prescription drugs abuse, it's making dealers and addicts of people with no previous criminal record. When we've had cases from as young as 15 and as old as 60. And it's sort of interesting, too, when you think about the methamphetamine issues over the past decade, and when I say that almost half of the cases that we're working now are prescription drug cases. And usually the cases that we're working are the larger sort of distribution. It's not, you know, somebody selling a one or two pills. And there's not sure where the recognition comes in as much as that there are some of the longtime drug agents that will say, yeah, you know, 6, 7 years ago, we're out trying to buy meth and deal with meth distribution. Somebody would say, yeah, but I got pills. But law enforcement wasn't necessarily even focused on pills as well. So the notion that almost half of our cases are now pill cases, who knows if that's ultimately just the rapid increases that we've been seeing, or it's also the rapid awareness. When I say ages 15 to 60, you know, one case, this was about a year ago, the Northwest Drug Task Force ended up dealing with, is there was a gentleman that was approached by strangers. He was in Plains, actually, outside of the pharmacy when he filled his prescriptions. And at one point, finally, after being approached by the strangers, that he started selling OxyContin. He was netting about $2,000 to $3,000 each month for 80 pills until he's arrested by members of the Northwest Drug Task Force. On the one hand, I mean, this wasn't somebody that actively became a distributor or seller. He was literally approached, and anybody on a fixed income could certainly appreciate at some point the temptation. I think that, do we have any emergency room docs here? One, I won't actually make you stand up or anything like that. But if you visit with either any of these drug task force officers or visit with some of the emergency room doctors around the state, and at least my experience is that you'll hear horror stories at times of doctor shoppers or pill seekers. Armed robberies. Think about what happened in Helena about a year ago. Bergam Drug gets hit twice, I think, in a week. Robbed at gunpoint a couple weeks later. Missoula certainly isn't immune to this. In one case that we had been working on for a while, 24-year-old woman from eastern Montana had 25 different doctors in 7 different communities. One trip would take 832 miles. She made that trip multiple times pill seeking. She'd pull the caps off her teeth to get drugs. We ended up, I guess, bumping into her more or less on her third car wreck. Her first two were intentional. The third was inadvertent. And that's how then they ended up with, caught into the Division of Criminal Investigation. The consequences are deadly. Part of my department is also the Forensic Science Division, or the Crime Lab, which is here in Missoula. In 2008, the Crime Lab found that the most dangerous prescription drugs were present in over 300 deaths, 321. Compare that to methamphetamines that had 13. And when I first heard that, I said, now wait a minute. My father, who was a stage 4 lung cancer patient, what did he die of? I mean, he certainly had a lot of morphine in his system. These are unattended deaths where there's no other cause of death other than, prescription drugs isn't necessarily the only thing, but it's a contributing factor. And it's more than, I think, just the cop side of it. And it certainly is much more than the cop side, as you all deal with. And more than just safety, it's also a pocketbook issue. Coalition Against Insurance Fraud estimates nationally $72.5 billion are spent each year on diversion, abuse, and unattended treatments and things like that as a result of that. So that hits everybody's pocketbook, and it ultimately touches every facet of our state and our communities. We've been working on this, dealing with some of the issues with prescription drug abuse since I took office. Number of different things that we're doing and trying to undertake, one of which is the law enforcement side. Got a $1.2 million federal grant to make a prescription drug diversion team. That has 3 investigators, one of them's here in Missoula, 1 prosecutor that all he does is prescription drug cases, and an outreach and education individual. And the thought is, in part, with a prosecutor that can go to any of our communities at the invitation of the local county attorney, is that this is all part of an education process where even some of our county attorneys would say, we got a lot on our plate. So here's an individual that'll just handle those pill cases if necessary. We created an advisory council. An advisory council brings together a wide range of people from criminal justice, medical communities, statewide, that working on devising solutions and raising awareness. And we're working on raising public awareness. When I look at the successes, if you will, of the past decade, where either government or others were involved with methamphetamines, I think that we did a number of things. One of which is we were vigorous in our law enforcement. And another of which is we passed some legislation. We put pseudoephedrines behind the counter, made supplies substantially harder. And another thing is that we educated our people. The Montana Meth Campaign spent millions and millions of dollars at least getting people to talk about it and at least raising awareness. So I think that we need to do some of those same steps in this area. With our raising public awareness, I don't have millions and millions of dollars, so if anybody does, I'd be more than happy to sit down with you afterwards. But we're working on a public education campaign. With the assistance of private foundations, businesses, darn near holding bake sales, my thought is until people are aware, not just, this is, as far as the challenges would be preaching in the choir, but until we across the state are aware of some of the challenges that we're facing, we're never going to change the dynamic. So just met, I guess, last week with the creative people, and we're working on trying to figure out a good statewide sort of public education campaign. In addition, I think what we need ultimately, and is critical from my perspective, is to give those in the medical profession and pharmacists the tools that they need. Montana is now one of just 3 or 4, one of 9 states that doesn't have a prescription registry. And the prescription registry, a pretty simple idea, it allowed doctors and pharmacists to access a database with their patient's prescription history on these specific drugs. So the doctor then has the tool of saying, is this a pill seeker or is this someone in need? 40 other states have figured out it's a good idea. Montana, it's been in front of our legislature twice. It's twice died. We're now in the center of the donut. South Dakota just passed it. How can we be one of now, and I think those that have passed, even if it's not funded, the number's like 43 or 44. It's insane to me because this is not a law enforcement tool. This is a public health tool. This is giving doctors the tool that they need. I mean, interestingly, the story I spoke of the one woman who went 832 miles once on a round trip, emergency room doctor in Helena had offered that he saw that woman twice. And twice in the emergency room in the evening, and he was the only common factor that night between the two nights. Only the doc. All the other staff were different. It's not going to solve all the problems in the world, but many doctors in our state will struggle. I mean, we want to do right as medical providers, and we want to make sure that those individuals that Kay starts out at the beginning get the medicine that they need. They should have all the tools to help make that decision. And it's something that ultimately when we look at legislation, we're going to be pushing this next session. I believe a broad coalition will be pushing it this next session. You know, it's interesting, as another part of one of the many hats that I wear at the Attorney General's office, I also regulate gambling. I have the Gambling Control Division underneath me. Earlier this week, I was at the Gaming Industry Association, and I talk about prescription drugs. And they can talk about how they are impacted as employers, as business owners. So it's something that once we start raising the awareness and we recognize the potential impact across the board, I think that our legislators won't make the third time, or maybe the third time will be a charm. But it's something that one group can't do alone. And it's something that ultimately all of us need to be speaking to our legislators about. Because you all who are on the front lines ought to recognize more than the Gaming Industry Association the impacts and the need to make sure that our healthcare community has the tools that it needs. I had the opportunity, which sounds a lot better than Attorney General, but drug czar, you know, Gail Kurlikowski, the new head of the Office of National Drug Control Policy. Met with him this spring as part of one of my national conventions. He says, yeah, this is becoming one of our very top priorities. And how can you not have a prescription registry program? I wish I could give him that great answer that, you know, we're just a little different in Montana and we don't need things like that. But it doesn't take a drug czar or a guy that owns a bunch of gaming machines to recognize that this is a tool that ultimately could make a real difference, and it has in some areas. As the state's top cop and top lawyer, I'll tell you, I don't believe by any measure that we're going to arrest or prosecute our way out of this problem. I think it would be not only naive but misplaced to think that's the case. I think that we need to do a lot more, and I think that we do need effective drug treatment. An arrest and incarceration will prevent abusers from breaking the law while they're locked up, but incarceration doesn't end the cycle of addiction or resolve any of the mental issues necessarily. We need accessible and affordable options in Montana for abusers to get help with their addictions and underlying problems before they become that ultimate impact on our communities. In addition, that was Tuesday, after I spent time talking gambling, I attended, or I was a speaker at a reception for the Yellowstone County Family Treatment Court. And the family treatment court, the principal deputy county attorney that works on it, Julie Pierce, she told me that, they're seeing an increasing amount more of their cases dealing with prescription drugs. And it's hard not to then see Mona Sumner of the Rimrock and her talking about the challenges that they're seeing. But what's inspiring, I mean, in some ways, that's like, boy, why get out of bed? It's just getting worse and worse. What's inspiring about going through like a treatment court graduation then, it isn't some guy in a suit talking, it's a graduate. And it's a graduate who can discuss, you know what? I've never had so many different people working toward the same thing. And that same thing was me. And once we finally got over our jurisdictional barriers and figured out that, social services and law enforcement and public defender all can work together and say, we want to change and make it, I'm tired of reading about statistics, we want to see more successes. That's what the Yellowstone County Family Treatment Court had to offer that night. And when I think about areas where I think we work effectively at times, another thing that we've been working on a lot is child sexual abuse response teams. I'll be darned if cops and prosecutors don't have a lot to learn from CPS workers and APS workers. And mental health folks, 15 minutes, I'm told. Don't worry, I won't take all my time. The PowerPoint's coming soon. When I look at crisis intervention teams, Law Enforcement Academy, where we train peace officers, is also underneath me. 2 decades ago, there was no instruction on mental illness. And now, when we're out there doing trainings, going from community to community, having law enforcement get to know the mental health community. It's when we can work together across necessarily our jurisdictional boundaries where I think we're all much, much more effective. So I applaud you here today. It's a daunting task when they say, here's what's the outcome of all this is going to be, is that in addition to the federal deficit, world peace, everything else, by the end of a day and a half or whatever, you're going to solve all the problems in our communities. But I applaud you for the notion of how can we better work together and what can we do to change the dynamics that we're seeing in our communities. We know that early intervention will lead to more successful treatment. We know that it keeps both the individuals and communities safer. And like you, I believe that by recognizing the signs and symptoms of abuse early and working on that, we're much, much more likely to end or at least curb all of this then, ultimately, the migration in the criminal justice system. Team approach to treatment, just like those other areas in rehabilitation at the community level, I think has tremendous potential to make the difference. As members of our communities, I think there are other steps that we can take as well. Our families and communities need to be aware of the problem and how to prevent it. Why is it nationally that 78% of the parents talk to their kids about marijuana and alcohol, less than a quarter about prescription drugs? We also need to make sure our policymakers appreciate the magnitude of the issues that you face and some of the potential solutions. That's where you speaking to a local legislator about prescription drug abuse and the necessity of having a registry is going to make a heck of a lot more difference than me speaking about it. You're their constituent. They need to hear from you. And as I mentioned earlier, 70% of the drugs are being supplied often unwittingly by friends and family members. Dangerous drugs aren't only sold in back alleys, they're in our medicine cabinet. Not too long ago in Billings, you could have read the Gazette about a realtor. And the realtor would go around right before open houses, go through medicine cabinets. Think about what you might have in your medicine cabinet. My oldest is 8 years old. That's no excuse, but why do I have that hydrocodone from 3.5 years ago, maybe 4.5 years ago, when all of a sudden I was in Idaho and had a tooth issue? Why do I still have that? I think that we need to change that because this is a supply. And if 70% of drugs are coming from friends and family, taken, purchased, or given, here's that open supply. To encourage people to clean out their old and unused prescriptions. In about 2 weeks, my office is teaming up with communities across the state. We have 30 of them signed on so far for Operation Medicine Cabinet Montana. The idea is pretty simple. We know we have these drugs in our houses. We don't want to flush them down the toilet or dump them in the river. We're going to end up with four-eyed fish. So let's get rid of them. And let's turn them in. In Missoula, for an example, all 5 fire stations on June 5th, you can just drop them off there. Ultimately, they're incinerated. Missoula led the way, actually, with take-back events. Is Carrie here? Carrie Sproul from the health department held one a little while ago, and they got 180 pounds. Got a glass pill bottle from 1951. Think about the things that we keep in our cabinets. So the more drugs ultimately that we can take out of harm's way, the safer our communities will be. And also by doing this, this is a way to raise awareness with your friends, with your kids, with your family members, with others. And I hope you'll get the word out. Take a look at DOJMT.gov. There's a big click on Operation Medicine Cabinet. We're going to be trying to do some additional publicity on it. There's some radio ads that'll be coming out. Blue Cross Blue Shield's helping us out a bit with that because, again, they recognize that the cost ultimately is borne by you and they. And it's one more thing that can make a difference. But ultimately, just like the drug court, just like so many things, none of us are going to be able to do this alone. And we need to work on these areas of raising the awareness, of changing the legislation, and changing the dynamic together. Appreciate the opportunity to be able to kick off your conference. I'd be more than happy to answer any questions for the 4.5 minutes I have left. My 2 assistants, woman with microphones.
Do you see the legalization of marijuana, but yet the dysregulation of it? Speaking from personal experience, I have one right in front of my daycare, right where the kids in Lolo walk past. I know it's supposed to be addressed in the next Montana session, but I'm wondering if there's anything we can do safety-wise to assure that it's going out as it should and that it's all safe to keep us and our families and our kids safe before that next session.
What can we do before the next session? Every community in Montana is struggling with that right now. So I wish I had that great answer. I mean, you had a well-intentioned citizens initiative that passed by 63% with no framework underneath it. And yeah, we're one of 14 states that have medical marijuana, but why does Missoula have more dispensaries than Seattle? Why is it easier to open up a grow lab than it is a nail salon? And that's, I mean, what has happened in Montana, and there are, this isn't to denigrate the initiative process, are those that truly need marijuana and use it as medicine. But what happened is you passed this great sounding initiative without any framework underneath it. And, I mean, boy, Bullock's real smart. I mean, we all know that, right? The proponents are saying we have some issues here. The first interim committee, we helped try to put together, here are some of the different sort of facets, just so that the legislature can appreciate that. And is Diane Sands here?
I think she's coming tomorrow.
Okay. She's co-chairing this committee, which is wonderful. But went from, here's the city manager, here are some of the things that they're facing, here's law enforcement, here's across the board. What to do immediately, I don't know. And I wish I did, and I wish there was a more fulfilling answer than that. But like in those other areas, to the extent that you're feeling the impact, you need to make sure that people hear that. And you need to make sure that it's heard next session. I mean, it's all that much more challenging in some respects because it's housed with the Department of Public Health and Human Services, and they were never given any resources. People call over to us, say, well, what can you do about that? Well, no, I mean, we can bust drug dealers, but they got to be actually drug dealers. And ultimately, you know, I think that there's a lot of, I mean, the slate is pretty clear right now, or a lot of ideas out there. I am, I guess, cautiously optimistic that there will be some changes to get closer to the intent of what the Citizens Initiative was that passed.
Yeah, I just had a question. In that registry, with the pharmacies, with pharmacists and doctors would have access to it as well, right? They should. Who else would have access to that registry? Who would, like law enforcement, they wouldn't have access.
Well, and that's always been, I think, one of the concerns is that, you know, I'd have this nice little computer that I could just look up and say, oh, that Kay Norris, we know that she's on those things. And ultimately, it would be, the only way law enforcement could get it is by search warrant or investigative subpoena. I can get your records right now by a search warrant or investigative subpoena. The case would have to be built in advance. Doctors and pharmacists, I think, are the only ones that were allowed. I was double checking with Lili Yamamoto, who's with the Board of Crime Control, the last session when it died. But so I mean, law enforcement could get it, but we can get anything if we talk a judge into it. Kristen.
We have the governor's support.
To repeat her question, do we have the governor's support? I have not directly spoken with the governor yet about this. And in some respects, I haven't spoken to a lot of different groups, because again, until we even recognize that there's a problem out there, and it's going to be a tough budget, you know, a tough fiscal session next session anyway, we can get some federal dollars to start it up, but I haven't approached them. I'm hoping that there's going to be such a groundswell that I won't even have to approach anyone else.
So that would be a decision maker people could contact too, besides just legislators.
Certainly could be, but we're pretty early in. I mean, we're just recently had to start submitting our proposed legislative things that could have a fiscal impact, and we'll end up having that conversation. And I think that, I mean, the compelling case can be made that this will save money long term. Corrections budget isn't small.
Hi, Mr.
I'm sorry, not to offend anybody in corrections, and I don't want you to get pay cuts. Please.
Mr. Bullock, my name is Jim Mason, and I've been an addiction counselor for over 20 years. And I worked a lot. I have been working a lot with adolescents until recently. My concern is, you're right, you know, the opiate drug issue is huge, and it's huge in our community and in our backyard. But my experiences, and here's an example, in the early 1980s, we took on cocaine, and it was a big deal, and we really focused on it, and guess what? We got smacked by crank, you know, right behind that. So I'm asking you, as the head person here in our state, are there ways to really focus on the big picture? An example is we still have one of the highest rates of alcohol use, abuse, and addiction of young people in the country, you know, and people kind of laugh it off like it's our culture. And it has spread into other drug categories, and addiction is addiction is addiction. So my concern is, where is some good budgeting coming from, some good planning, and some really strong intervention? The earlier, the better.
And I don't disagree. And if you had figured out that within the last 25 years, none of us would have been here, and that's the problem in some respects, is we squeeze on one thing, it's going to go elsewhere. That's why, you know, I barely got a chance of getting the registry passed. I don't know if I can solve all of society's ills. But in all honesty, then, we've also done a number of different things that I don't know that every attorney general would do. That I've made a statewide award for mentors and after-school providers, because we know kids that are actually given, a solid role model are much less likely to commit acts of violence, skip school, or get involved in drugs and alcohol. Been involved with Fight Crimes, Invest in Kids, and saying early childhood programs are critical. And that doesn't solve, the overall dynamic, and the hard thing to ultimately convince a legislature or others of is the investments that you can make in treatment and in education and prevention. It's going to save you money down the road. How to bring all that together and how to make that the reality in Montana, which I'm not certain that it's been a reality anywhere in the country. It's a struggle. With alcohol, we've been working a lot on DUI and the multiple DUIs, and done some stuff with underage drinking. But it's, you present the sort of question that it's like, man, I don't want to get out of bed in the morning.
I do want to get out of bed. I want to join you. I really appreciate what you're saying and what you're doing, and I'm not here, to criticize you or argue, but, I'm up for this, and if you're up for it, I'll try to help you. You just tell me some ways that I can do more, say more, ask for more, and I'll do it, because this is a big deal in all of our lives, and it's generational.
And it is. And it's voices, though, that, your voices need to be heard in the legislative process. And your priorities need to be heard. Because if not, it's easy. These are hard issues. You all deal with them every day, and But if those voices aren't, if that's not part of our priorities from the ground up, it doesn't change. And I'm not so naive to say, okay, we get this registry in, we do education enforcement, life is going to be a heck of a lot easier. In some respects, if we can change the dynamic, and at least, because I believe at least that prescription drugs are a lot more challenging than cocaine, meth, crack, because they're legitimate, important drugs. And because a kid doesn't even know when he's mixing pills. I'm not going to say that the next thing that we're going to get is going to be better, but I hope through all this that it's an education process that maybe we all get a little bit better.
Sit on. Black button up.
I can speak up, it's okay. In terms of your prescription drug registry proposal, I encourage you to remember that nurse practitioners and physician's assistants also have DEA licenses and prescribe a lot of these, and hopefully they would be included in the registry.
Yeah, and indeed, I'm virtually positive that they would. It's the DEA license it's prescriptive authority is what it's been in the past. And point well taken, too, that I sort of like all lawyers are the same, all medical providers are the same, and we.
I'm Scott Elrod. I'm the medical director of the Western Montana Mental Health Center. And if I wanted to go out and get a large supply of very fun pills, I know exactly where to go in this town. And I didn't learn that myself. I learned that from people I talk to every week. And so I was wondering if you had any plans for putting the squeeze on these providers.
I guess I don't spend enough time in Missoula, so I'm not sure where you're going, Scott, on your off hours.
No.
No.
It's in offices.
Yeah. You mean specific docs, or?
Yeah.
Yeah, and my focus is on with this registry, which could change the dynamic of all of it. I mean, I'm not going after doctors at this point, or I don't have plans, okay, Bullock gets the registry, and then I'm going to get back with Scott and figure out exactly who to go pop. I mean, it's a public health problem across the board. And ultimately, would some of that shake out? I don't know with the registry. We'd have to see how that works in other communities, in other states, in the 43 others that figured it out. There are drug task forces all throughout the state. Do some of them get involved with provider issues? Yeah. Oh, please.
I was just wondering how you feel about the methadone clinics that are opening in Montana.
I frankly don't know enough about them to feel. I mean, I just haven't been involved in them, and not trying to sound like a politician to duck it, but I don't, as my 8-year-old quickly recognizes, I talk about a lot more things than I know about, so I'm ill-informed, so I won't. I hope that's...
Anyone else? Other questions? 4 minutes.
Prior to there being legislation for the drug registry, is there anything that can be done inter-facility-wise when they're suspicious?
The question was prior to a registry, is there anything that can be done between whom and whom? Is the
Hospital emergency departments, physicians' offices, pharmacies.
I think, and some of you in this room would have a better grasp on that than I in some respects. I think it's a real challenge, and that's why if you go speak to the emergency room doc, what can you do? And that the pharmacists can't necessarily be picking up the phone. You know, I think the St. Pete's Pharmacy has put people, when they come to the emergency room, and get prescriptions from their pharmacist in the hospital on a pretty short rope. But the communication and that sort of tool, I think we're going to have a registry before there's any real meaningful change or opportunity there. Please.
Actually, I can speak to that. I have, there's a physician in Spokane, Washington. If you go on to ConsistentCare.com, he has a really good program, Dr. Darren Nevin, and they have an excellent program throughout Spokane. And they have actually there's a computer program or a company that provides software that links all the emergency departments in their program. And there's a link to that on the ConsistentCare.com website. But it's been pretty successful, according to Dr. Nevin, so something you can...
And was that, this goes back to my earlier comment about my 8-year-old, is that, I mean, requiring legislation, or a bunch of providers just got together and said, let's share information?
Dr. Nevin has actually testified in Washington to try to get that through. And there's actually some other legislation that he testified to get through, but that was another big thing that he did. But no, I think it's between, they have guidelines, opiate prescribing guidelines based on the task force in Washington, and they put all of their resources together in the Providence system, and develop their own guidelines based on the Washington State task force. And yeah, they have guidelines and a protocol. It's very specific. There's a specific set of things that happen when someone that is admitted to the Consistent Care program, their name becomes part of this system, and all these things start happening. Their primary care provider gets notified by email. I mean, there's all this stuff that goes on. It's a really good program, and I think it should be adopted in other cities. So. We have time for one more.
Well, I'm Steve Cohen. I'm a family physician who was also boarded in chronic pain, and I work mostly in the emergency room on the Crow Reservation currently and run our chronic pain program. And Kay asked me if I wanted to say something about the challenges of going after docs. And I spent a significant amount of time in the past in the pain clinic in Billings, and I know that there are a small subset of physicians out there that are outliers because I've inherited a number of patients from them. I actually think that compared to some of the other mechanisms, between the DEA, State Medical Board, there are good ways to address that are already set up, and there are processes in place for that. But we need to realize that, chronic pain addresses more patients than, diabetes, cancer, and heart disease. And it's already undertreated largely because most of the docs out there are afraid of being gone after. The registry, having been in states where there were registries, and, in Billings, you get a lot of patients from Wyoming, and Wyoming has a registry, so if you get patients from there, you can use the registry. It's a no-brainer. I don't know why we don't have it. It should be a slam dunk, and it really cuts down on a lot of the good docs getting beat. But it is working together and collaborating. Education is probably the main tool. People always come to me, how do I interpret this drug screen? Because we do a lot of drug screens. If you're in the ER, you need to, and someone comes in for a non-acute pain problem, you need to have a drug screen before you leave. Those are simple things that need to happen because, I prescribe the most pain meds in our facility, but I also do the most drug screens and send a lot of unhappy people out of the ER because, headaches, back pain don't belong in the ER. Fortunately, we have a dental clinic, so it's easy for us. Dental, one area that needs to be addressed is for kind of the Medicaid level patient, dental access is difficult. And if the dentists were on board with providing indigent care the way the physicians are, that problem would go away because we don't have that problem on the reservations because we have dentists. And we could say a lot more about this, but I'll stop there.
No, and I appreciate that in a number of different respects. One of which is that, at least on a national level, too, it's lies, and statistics, but 70% of physicians have said, we need more education on prescribing. And interestingly, 2 weeks ago or so, maybe 3 weeks ago, I had a all-day meeting, first at Crow, then Northern Cheyenne, and at Northern Cheyenne, the administrator of Indian Health Services came, talked about what they were actually doing with electronic medical records, said, we have a bunch of patients that get real upset because they can go over to Billings and get the same medicines we denied them. So there are a lot of challenges out there. Am I done? Yes. Are you done with me? Apparently, the big hook is coming. So I certainly appreciate the opportunity to spend some time with you this evening and hope the next couple days is fruitful and productive.
Okay. Well, Kay is finding us a tech person. It's my great pleasure to introduce Joan Cassidy. I've had the pleasure with working with Joan for about 9 years. Let me just take this and. Oh, great, you're awesome, you're here. Okay, let's step over here. Don't pay attention to the people behind the curtain. Okay. Joan Cassidy is the Bureau Chief and Single State Agency Director of the Chemical Dependency Bureau, which includes the Montana Chemical Dependency Center. The CD Bureau is a branch of the Addictive and Mental Disorders Division of DPHHS. Joan has worked for over 30 years, hard to believe, in the field of substance abuse treatment and prevention. and has actually just recently been presented a Lifetime Achievement Award from the Montana chapter of NADAC, the National Association of Alcohol and Drug Addiction Counselors. She currently serves as the chairperson of Montana's Co-occurring Transformation Team and is a member of the Montana Systems of Care Advisory Board, the Montana Tobacco Advisory Board, and the National Association of State and Alcohol Drug Abuse Directors. Just returning from Disney World and Splash Mountain with her grandchildren, I present to you Joan Cassidy.
I also, as with Steve Bullock, like to thank Kay and Tamara for the invitation this evening. It's a wonderful opportunity, not only for this area, but for the state of Montana. As our Attorney General referenced, the addiction that we see in the increases with opioids, you'll now see, as I have, within the publicly funded treatment system. One of the areas that was asked, and I see many faces in which that I work with in the state-approved programs, but was to offer those in attendance to truly know what the state of Montana does related to the publicly funded treatment and prevention system. The chemical dependency roles and responsibilities, we have primarily oversight for the policy and development and to provide alcohol and drug prevention services and treatment in Montana. That meaning we work very closely not only with the Department of Public Health and Human Services Director, but also the governor and other agencies in setting policies that are related to substance abuse and for treatment and prevention. The services that we reimburse for include high-intensity residential, outpatient, and prevention services. The Chemical Dependency Bureau, as of July 2009, I was given the wonderful opportunity, inheritance, to oversee Montana Chemical Dependency Center in Butte. This is a 76-bed residential facility. Prior to that time, it was under another responsible party within the Addictive and Mental Disorders Division. Truly, this was a change that came about on the level of the department. When the department director looked and really felt that a high need to connect residential services with the continuum of care, the change was made, and it was made very positively and supportively at a high level. In Montana, we're blessed with state-approved programs in all 56 counties of Montana. The state currently has 37 state-approved programs throughout Montana. As we speak, we could have 2 more. Prior to my arrival 6 years ago, we saw a very stagnant line of state-approved programs through Montana. Knowing the need for treatment and the unserved populations in the state, we have recruited and really looked forth for many opportunities for individuals willing to start beginning to serve populations both in prevention and treatment. One of the areas that I feel very encouraged by, and it's been a tremendous step for them, is that we now currently have 7 state-approved Native American programs, both urban and tribal. This was one of my own personal goals, knowing that the tribal communities and the urban have many, many problems related to substance abuse. And it's truly been a pleasure to have them join with us within the state approval process. The Chemical Dependency Bureau contracts with 23 of the 37 programs. Those programs located throughout the state provide an array of services, direct services, and also, as referenced, the ACT program, which is the DUI program for offenders. Montana's community-based treatment and prevention system, we have 7 recovery homes, 2 located in Bozeman, 1 in Miles City, 1 on Rocky Boy, 1 in Great Falls, Kalispell, and Livingston. We have 2 women and children's homes. These are homes located in Missoula and Billings. This is where moms and their children stay anywhere from 9 to 15 months. On the average, we find moms generally have 3 children, younger children under 12 years of age. And it's been wonderful to see the growing that we have with moms and kids working together when there's an addiction problem. We have 2 adolescent community-based residential homes, 1 in Billings and another one here in Missoula. This came about approximately 4.5 years ago. Prior to that time, we had contracted with a private provider, and when we were unable to fulfill the rate increase that they had requested, we put out a real quick RFP, and Missoula and Billings stepped up to the plate, and we had 2 homes, community-based homes for kids within like 6 months. So yay to Missoula and Billings. We also have one transitional living home for men located in Helena. That was the original home in Montana, and it was, I believe, developed and implemented probably in about 20 years ago. And then we have Montana Chemical Dependency Center, which is a freestanding residential in Montana. The outpatient programs are 23 programs throughout the state, located in different communities. Those communities, some of the highlights that we see is the intervention programs. We have in Livingston, the family intervention, the Bry adolescent intervention in Great Falls, and of course, Project Success in Missoula. And I have to say I have somewhat of a bias because prior to my coming to Helena, I did work for Western Montana Addiction Services and was truly impressed and felt to be a gift to be a part of that community. We also have prevention programs. In Montana, we do the Prevention Needs Assessment Survey, which is given on the off years of the Office of Public Instruction. The P&A, we survey approximately 35,000 youth between the 8th and 12th grade every other year. As referenced earlier, Montana has no reason to be proud as we are one of the top in the nation with underage drinking. We have many, many problems to address. We also have the state strategic framework state incentive grant. It was a large grant that was awarded to the state of Montana and the Chemical Dependency Bureau 5 years ago. We are in our final year. It was a $12.5 million grant, and it has worked. We have 28 counties throughout the state, or 6 projects that are working on underage drinking. It's been a wonderful project, and it's also been great to see the success of smaller communities that were awarded the opportunity to work and address prevention issues in an environmental project. The chemical dependency funding, as referenced earlier, funded this program through the Center of Substance Abuse Treatment. The federal block grant, which is referenced as the SAPT, it's a Substance Abuse Prevention and Treatment Block Grant, is approximately $6.488 million per year. Montana has been, although that appears to be a small amount, we've been able to maintain our funding source without decreases over the year, minor decreases. As most federal funding, we know that their increases are not generally are what we're going to see. We also have alcohol tax dollars, and the alcohol tax dollars come in twofold. One, there's a small portion that funds the Chemical Dependency Bureau projects. We have another, which is not referenced here because it's not under our control, but we send just over $1 million to counties through alcohol tax dollars. That money is then redirected to county programs, state-approved programs, according to county commissioners. Montana Chemical Dependency Center has just under $5 million in alcohol tax. In the 2007 session, when we were all very much aware of the methamphetamine problems in Montana, the governor of our state and the Schweitzer administration very favorably looked. Montana had never received general fund money in the history of Montana for the treatment of addictions. In the 2007 legislative session, we were awarded $2 million to set up 5 recovery homes and 12 beds for 3-5 to treat methamphetamine and other addictions. This was a tremendous step for Montana to receive this funding. And as we know, this money came about from folks like you coming forth in the legislative session, telling legislators in your community and at the session how important addiction is. We also have a small amount of Medicaid. We have 1.5 million. Our Medicaid fund is not Medicaid general fund. We have a special funding that was created some years ago. And our SPIF-SIG, we averaged 2.3 million a year. So totally, we have approximately 15.5 million annually as a budget. And for those of you who know, that is not a lot of money to treat the needs in the state of Montana. Currently, some of the Montana initiatives we work with, the Bureau has looked at the NITEX project, which is the Network for the Improvement of Addiction Treatment. NITEX is a process improvement. It looks at reducing wait times, increasing admissions, increasing continuation in treatment. It's been wonderful. The process, which has been very cost-effective, was developed by the Robert Wood Johnson Foundation. Currently in Montana, we have 75%, including Montana Chemical Dependency Center, of our providers that have voluntarily enlisted in working with the Bureau in this process. We all know that treatment, if it's not timely, doesn't work. There's no one that knows that a meth addict or an alcoholic that's out on the streets for 5 or 6 weeks isn't going to wait for a slot for treatment. And this is a mechanism that we've been able to integrate into the system that we hope has made some changes. We also have the co-occurring transformation team. This is another piece that, working with the Mental Health Bureau, the Chemical Dependency Bureau, and Mental Health now work together, and I know that some of you here are involved on that team. We provide a lot of clinical training, we do a lot of policy development, and working better to how can we serve the people better in Montana. Montana was also, I have been working in developing of a new substance abuse management system called SAMS. SAMS, as we all know, without data, we do not look to have financial resources. The days when you can say, trust me, we do good work, doesn't work. We all need data. SAMS has been, I have to say, one of my greatest challenges in my career, but I can also say as we're coming to light now when we look at being able to meet national outcome measures and we're looking at quality assurance, how can we do a quality improvement with clients, it's been wonderful. And also the new program, for those who might have read about, is Prime for Life. Prime for Life is the new DUI curriculum, mandated curriculum for state-approved providers. It will be fully implemented by September 10 of this year. Evidence-based, therapeutic, and engaging those participants coming in to enroll for a DUI. We also look at process improvement strategies. We all know we can do better. We look at referral satisfaction surveys, both for the Bureau and Montana Chemical Dependency. We just sent out our client satisfaction survey. looking, how can we serve you as clients, or how can we serve you as providers better? We also have a universal application process that's in the making. One of the ways that we look, as we look at this continuum of care, and I've often questioned in my 30 years of career, that when as a client coming into a facility, that I go through this 10, 20 questions, what is your name, the demographics, and then as you move along, we go through another 10, 20 questions, the same demographics, and it's like repeating the story. So within the next few months, we have a universal application that will be implemented through all state-approved programs. Very excited about it. Also within that, it collects national outcome measures, and it will do our performance measurement for Montana. Our primary drugs of choice, 2009 admissions, overall we had approximately 7,500. 63% of those primary admissions are for alcohol, 18% are for marijuana, and 10% of primary admissions are for opioids. We know that as we looked, and I can say in 2007, methamphetamine, if we were to look at the other remaining percentage here, are about 7.5% now. So meth is dropping, opioids are coming up. And I believe, as Jim Mason had referenced, that's generally what we see. We know as addiction providers, when we're looking through this, we need to look at addictions because addictions do change. Barriers and challenges, always stigma and attitude, always the need for more education. When we look at those individuals coming to our treatment, whether it be the residential or whether it be outpatient, we know we see just as many professionals as we do those individuals. We know infrastructure and capacity. We all know with healthcare reform ahead of us, the addiction side and the mental health has a tremendous amount of work ahead because we have a lot of people in Montana to serve. We also know that we have treatment gaps, but we also know we're addressing them. I feel very optimistic in the tenure that I've been working with the Addictive and Mental Disorders Division, and especially under this administration, we are working closer together to fill those gaps, whether it be in treatment and in prevention. We also know workforce. As you hear the term, the graying workforce, we know especially in addictions, many of us are at the place where we're looking at retiring. As I had my 7-year-old grandson tell me this past week when we were in Disney World, Grandma, don't you want to just stay home so you can spend more time with your kids? It's like, okay. And access and timely access, access and timely admission. We know that we have wait lines in most areas of Montana. And building bridges between systems, working together collaboratively, whether that would be with law enforcement, whether it's with doctors. We have to, especially in the economic times we're in, we know that we have to work closer together. We've got resources available. I know there's handouts where if you can go into our website. We also work very closely with the Prevention Resource Center. Just recently, the department director has aligned and offered the Prevention Resource Director to work closer with me on the prevention side, and she has a tremendous amount of resources that we can provide to communities. And as I saw the little sign go up, I will also ask if there's questions.
There's a group trying to qualify a alcohol tax initiative, and it doesn't increase the tax, but it changes where the money goes. Does that impact the money going to your division? If it passes.
If it passes. It is my understanding that what I do know about this, it would take money, alcohol earmark tax money that's now directed in another area to fund other treatment courts. The piece that I'm not clear and I could not provide information on is how that would be backfilled. But it would not impact our dollars. Or we hopefully know it would not impact our dollars. And I believe it was a small amount. I think it's about $5 million.
I have a question. On one of your slides, you say fiscal year 2009 admissions to treatment 7,498. How do you define the phrase admissions to treatment?
Admissions to treatment, those are the admissions that are coming into the state-approved programs. Those admissions come in through the 37 state-approved programs that are submitting data to us that we're providing anywhere from outpatient, intensive outpatient services. So
then does it not include MCDC and the contracted agencies?
those contracted,
The other ones?
those are then a part of being a contracted vendor with the state. Those individuals are required to submit data, which is through the SAM system. So if those individuals, say in Western Montana, submit data, they would be a part of those admissions.
I guess the reason I'm asking is somehow that seems kind of low to me, that only 7,400 people are. I mean, I'm not being critical. It just seems, I'm thinking, wow, it seems in Missoula we have hundreds and hundreds of people, thousands, going to treatment.
If you were to look at the funding mechanisms, if you were to break that on the treatment, out of the 6.5 million, just under 5 million goes into treatment, and then we have $2 million for meth. So we're looking at approximately $7 million is what we manage into community-based treatment.
Okay. Thank
It's pretty
you.
small.
Thank you.
So it looks like there's a lot of treatment programs, but where's the best way to find out exactly what they are in our city and how to access them? If someone was to say to me they wanted treatment help, which they haven't done yet, but I really wouldn't know what the next step would be.
Okay. There's a couple ways that we can tell you how to find those programs. One, if you look on the handouts that was here and look at the resources, if you go to the Addictive and Mental Disorders website, we do have a directory of all the state-approved programs in Montana. Right alongside of those programs, you'll find what it is they provide, what's the level of service and access, how you can find them.
And that's also part of the resources that we're going to be emailing to everyone. Is we're going to be sending you that link so you can readily access it. We have another question here.
Hi, Joan. I just want to thank you for, I guess, being in charge of Montana Chemical Dependency Center and taking a look at it and surveying all the providers and all of us that refer over there, and also the clients that go through there. And my question is, once the surveys come in and we do this, 1 year gathering of information, is there any way that that hospital can be accredited under national standards where we make sure all the therapists are licensed, the paperwork is done properly, the services are provided properly? I mean, is there any way in the future that we could possibly get an accredited state-funded treatment center?
I appreciate the vote of confidence and can tell you that I had many mixed feelings when I knew that the transfer of responsibilities was coming my direction. It was also most difficult because I live in Butte. And for my 6 years prior, it was real easy because I could just say, talk to Deputy Bob. He was overseeing. I'm optimistic that time, often since July, hasn't moved as quickly as maybe I would have liked to, but there will be changes. I have 110% support of the department director and the governor to make the changes necessary. I believe everyone here knows not only the critical need for the services, but the leadership and direction of a valuable resource that's very limited. But I do feel that I have the support to navigate to the standard that we need there. And I know that the survey results are coming in. I've been given full opportunity whenever I've requested to hire some extra consultants to help me in this process. It's worked. And I'm optimistic that we can make the changes to make this a facility accredited, such as some of the others within the state. Because there are standards of care that I have, and I believe, that are much higher than what have been happening in the facility. And I am optimistic that we will get there.
Thank you, Joni. I hate to get back on my cause here, but one of the neatest things that, I think the guy's name was William Clark, that sent out a letter and set up the school-based services program for adolescents. And I know you, that's been one of the things that you really work toward. And I want to know if there's any way to further develop that program and make it more broad-based and financially more feasible for state-approved agencies to continue that. And what that, it's a program, as you know, that allows a counselor to have face-to-face contact with kids that have been found to be at risk in schools. And I had the honor of being able to set that up in Ravalli County. And the first school we worked with, the first year, 39 kids were kept from being expelled and just booted out. I thought that was a big deal. And then I watched it grow, but it's always been one of those add-on things with, you know, sort of counselor dependent. And I just wonder, is there some way to increase and improve that, make it, you know, more accessible?
One of the areas that I believe will assist the state in building on that is through better collaboration. We know, unfortunately, on the federal level, when we look at prevention, the shift is coming more towards environmental, which is not a place that fits into this scenario. But there are other options with the collaboration that we have through agencies that I've been now working with, that I believe we can do more of the expansion. Also, the fact, number one, is because I believe in the program, I know it worked. I know it worked here in Missoula, I know it worked down in the Hamilton area, I know it worked in Butte, because that's what I did. And so I do have some of that belief. And often we look for financial assistance when that's really not what we need. We need to really look at how do we better utilize the funding and the resources that we have within our communities. How can we better utilize maybe some of the gathering and what we have collaborative efforts to learn to spread the word how they do it. And I know that each of us are going to have to we're going to have to work closer to do good work because there isn't going to be the funding there. Attorney General was correct. We know that this next legislative session is not going to be pretty. I know that as a state employee. So I would like to say I wish there was, but I believe there are some opportunities. One of the places I'm working with is the Interagency Coordinating Council. It's a governor's cabinet level. It's currently working on underage drinking, which is wonderful. Cabinet level individuals, leaders, identified a work group member to work with us. And Vicki Turner with the Prevention Resource Center and myself are co-chairing that with the governor's office to move that forward. Those are the ways in which we can move those kinds of programs. It's relationships. It's all what you do here.
Thank you, Joan.